Sir. Thank you very much for your introduction, and I thank the organizers and also AstraZeneca for providing the support for this meeting. So are the slides visible? I think that is the biggest challenge.
Yeah. Yes, they are visible.
So I think the life has been made easier by Dr. Rajiv anyway, by his presentation. And over the next few minutes, I have been told by the organizers already that this is the session where we are going to compromise on time. So we have to finish really quick in maybe 10 to 15 minutes. So some of the points he has already, I think, highlighted and made clear. So without wasting much time, we'll straight away go to the topic. And I think Dr. Surya Prakash is not here. Is that correct? So other four panelists are here. So Dr. Surya Prakash is not here. And may I request Dr. Rajiv, if he is here, to maybe be with us during this panel discussion.
Sure, sir.
Okay. So I also have a disclaimer that although I am doing this moderation, but till now I have not had the fortune to treat a patient with extensive stage small cell lung cancer with immunotherapy, mainly because of the cost constraints. Whichever patients we have treated, they have not been able to afford this medicine. So introduction about small cell, I think all of us know. And this has been the evolution of therapy since the early 70s with CMV. Then CAV was the gold standard treatment until EP became the backbone of treatment in 1990s for almost 2 to 3 decades. And now we have addition of checkpoint inhibitors. So this is the older trial, 1992, where EP was kind of showed similar survival results with CAV, which was at that time gold standard, and even alternating regime did not improve survival, which was, as Dr. Rajiv also showed, less than 1 year, to the tune of about 9 to 10 months. So coming to our case, which is of a 62-year-old patient with a history of 30+ years of smoking, presented with shortness of breath, hemoptysis, weight loss, early satiety, and his primary care physician found massive liver enlargement, and blood biochemistry showed deranged LFTs with the AST ALT of more than 3 times upper limit of normal. Then this patient had a CT chest abdomen, which showed a left lower lobe mass, mediastinal adenopathy, and hepatomegaly with multiple hepatic lesions. And biopsy from the lung mass showed small cell lung cancer, was synonymous with the small cell lung cancer. So I'll start with the questions from the panelists as to what is your diagnostic workup for a patient with suspected small cell lung cancer. We can start alphabetically, maybe with Dr. Anuj to begin with.
Very good evening, everyone. I think CT scan actually. Can we get back to the slide, initial slide? Okay, CT chest and abdomen was done, so that is has done the workup. But apart from it, as in all the small cell lung cancer cases, we also do brain imaging with the MRI to look for the metastasis in status in the brain. So apart from that, we would like to do that MRI brain, and now to know the response, although it is not guiding to the treatment, but again we will also like to do a PD-L1 testing, so we can maybe better assess how the patient will respond to the immunotherapy if he or she can afford.
Okay, so Ashwin, so you will do MRI brain and PD-L1 testing. Okay, Ashwin.
Yeah, for small cells, sir, if I could, patient is willing, I would do a PET scan and definitely new imaging. MRI brain, definitely, even if patient is asymptomatic, I'll do a baseline MRI brain to see what's in there. But I wouldn't do a PD-L1 for a small cell. I'll do a PET scan. Otherwise, technically, you need to do a bone marrow also, but then I would waive off the PET scan. So PET scan is what I would do if you could.
So
I'll do a PET scan and MRI.
Bone marrow for all patients with small cell, if they show like
Not if the PET scan is showing. I'm saying if you go for a CT scan, technically you would be recommended to do it. That is what we were taught to do. But I would do a PET scan if where I work, sir. So an MRI brain.
Okay, anybody has any difference of opinion? So MRI, I think, is standard. Everybody agrees that as part of imaging, we have to image the brain, preferably with an MRI. And CT, this is what the guidelines, the NCCN guidelines, which we are all fond of, suggest. In addition to the biochemistry and the CBC, we can do CT, chest, abdomen, pelvis with contrast. Brain MRI is preferred, and PET CT can be considered if limited stage is suspected. So this is what they suggest. And PDL1 testing, I am not aware whether it is definitely mandatory, because immunotherapy used in small cell does not warrant PDL1 testing. So this patient, in addition to the information that I already shared, performance status was ECOG-2. There were no other comorbidities. And a biopsy was also done from the liver mass, which was consistent with metastatic involvement, and brain imaging did not show any abnormal finding. So the diagnosis was clear of extensive stage small cell lung cancer with the liver metastasis in somebody who has been a chronic smoker. So how would you proceed? Dr. Saqib, what would be your preferred treatment for this patient?
Good evening. So for this patient, I mean, I would initially try to give carbo only, because the liver enzymes are already deranged, and try to just first get the volume of the liver disease down, and then subsequently escalate the treatment by the addition of etoposide and an immunotherapy. So in this patient, I would be starting with preferably single agent carbo first, and then escalating subsequently.
Right. So, and let's say disease responds, or both sides, if it progresses after one dose of carbo. So how much carboplatin would you be giving?
So, I mean, depending on the PS, if I think the PS is quite low, patient is not well, I'll just try to hit initially with OC2. Or if the patient is fit, I may go up to OC4 or OC5. And then see on a performance basis and response basis, and then decide subsequently.
Okay. Dr. Rajiv, this is something a little bit different from the patient that you discussed. So what are your thoughts?
So if the patient is patient is PS3 or 4, then I can give weekly platinum plus etoposide. Otherwise, PS with 0, 1, 2, I'll usually give to around full doses of etoposide, and carboplatin in first cycle. If the patient's PS improve further and the parameter further improve, then I'll substitute carboplatin with cisplatin, and then only I will add immunotherapy if the patient can afford.
Yeah. So I think that is what would be the real. Ashwin, any difference in opinion?
I did have a patient who was similar, but being heroic or stupid, I really can't say, but I used 80% of etoposide, carboplatin, and atezolizumab on that patient. He came on oxygen on a wheelchair, and I mean, I was actually pushed to do it. The family came prepared, but that's one of my things that I've learned, and he did remarkably well, 2.5 years post-treatment. So I would use etoposide at an 80% dose or 75% dose, depending upon his fitness. Immunotherapy, if you could, I would bring it on. I wouldn't wait for it. I mean, I would bring it, but I would not compromise on the etoposide. I would bring in etoposide, maybe 80 to 75% dose, depending on the fitness.
Yeah. Anybody else has any other difference? Dr. Anuj or Dr. Vikas? We have not heard from Dr. Vikas so far.
Sorry. I was on mute probably, and that's why it has happened. So for the baseline investigation, I agree with Dr. Ashwin that I would have done the PET scan. And for the chemos, I also agree with Dr. Ashwin that if it's a disease-related derangement in LFTs, the carbo-etopo works beautifully. So you give on a split dose regimen on day 1, day 2, day 3, and you see that LFT is magically improving. And I always tend to add or give a preference, if financials are not an option, to add immunotherapy to the patient as per the affordability. But it's always on the cards.
Correct. So, okay. So I'll also agree. So if we have to give the treatment, I would also give doublet to begin with, but probably I would give a lower dose of etoposide if LFTs are deranged, maybe about 50% or so in the first cycle, and then maybe escalate in the second cycle. And immunotherapy can be given, although the trials do include patients only with PS 0 to 1. So, but I think PS2, as has been mentioned by both Ashwin and Dr. Vikas, if it is solely due to the disease, I think it is you may make a case of giving immunotherapy, because this is something, it's a disease which rapidly progresses and may not give us time. So number of cycles that we give, any I don't think there is.
Kunal sir, I just want to add one thing. If the patient has as you told that the enzymes were deranged, one of my patient has presented to me with a bilirubin of 8. But the patient was fit, and bilirubin is because of liver disease involved. I have given that patient 80% of the dose of etoposide and carboplatin, and within 2 weeks, his bilirubin came down from 8 to normal to 1. So my only advice is that we should not compromise in etoposide in the chemotherapy dose, even if the patient's parameters were deranged. But patient should be in PS01 at least.
Correct. So I think somebody with a bilirubin of 8, I don't think that patient would be having a PS of 0 to 1. And
this patient which I am quoting, this patient has PS of 2, but
correct,
with bilirubin of 8.
Correct. So I may be wrong, but I think if you will go back to etoposide, and it's we are maybe slightly moving away from the topic, but etoposide as such, I think the package insert may say you may not have to change the dose based on the or like in hepatic impairment. But if the AST, ALT are more than 3 times or bilirubin more than 1.5 times, then you should be reducing the dose of etoposide. That is what is my reading or understanding of etoposide. I may be wrong. So we have heard about durvalumab, and I understand this is a AstraZeneca sponsored symposium also, but I don't think atezolizumab is that bad. So anybody has a preference of one over the other than durvalumab? Anybody in voting for atezolizumab? Any of the panelists?
So I have used atezolizumab in small cell, so extensive stage. I mean, for a disease that is really bad, I've had remarkable results. I mean, you can't be biased. It's only a single patient, but I had patients still 2.5 years down the line still alive. So almost 19 cycles of maintenance.
Okay. So anybody else in favor of atezo or strongly?
I don't think we can favor, because it depends on both the studies almost have almost similar survival, except for the fact that durvalumab, the Caspian study, had some brain patients who had some controlled brain metastasis in the study. So
yeah, so probably the two differences, I think I'm just trying to point out both kind of almost similar designs, but Caspian did involve patients who had brain metastasis, either treated or they were asymptomatic. So whereas in IM Power 133, only treated brain metastases were included, which were about 10% of the patients, both studies. And survival and PFS, there is hardly anything to choose from both the studies. Only other advantage of atezo is that if you are planning to use cisplatin in somebody who is fit, young, then I think durvalumab has the only data. We do not have data of use of cisplatin with atezo. And I'm not aware how you would counter the nausea, vomiting without using steroids, and what dose of steroids you would be using with immunotherapy, because that will be the other challenge. So just from everybody, how many patients of like small cell, how commonly do you use cisplatin? Dr. Sakib?
In extensive stage, we almost exclusively use carbo.
Okay, great. Dr. Vikas?
So carbo is as equivalent and non-inferior, so I always prefer carbo.
Okay. Anybody has any difference? Because as I said, because if we are using carbo, then both the drugs can be used, and they are showing kind of.
You are just left with 1 minute to conclude your panel discussion.
Yes, we are almost about to conclude it. So the only other benefit or the data set which is in favor of durvalumab is the 3-year update, which is showing about 17% of patients were alive. So again, close to 1 in 6 were alive at the end of 3 years, whereas the data set of atezo is mature for 2 years. We do not have the 3-year data mark. So PCI or no PCI again is debatable. And earlier thought was that patients who have good response should be given PCI, but I think there are contrasting evidence for that. Dr. Vikas, any one just small remark on PCI? Will you give for extensive stage? Dr. Vikas is not there. Maybe. Dr. Ashwin?
So depending upon the age, there's some data showing that age more than 60 or 70, there's no benefit of giving a PCA prophylactic. So that's one thing. So that is one thing I look into.
Caspian did not allow giving PCI. So if you are planning to give PCI, I think the only drug which has some data is atezo, because 10% of patients in that.
But thoracic radiation is not allowed.
Thoracic is not allowed, but only PCI. 10% of patients in IM-Power did get PCI.
Dr. Kunal, 1 more minute.
Sir, we have already finished. So I think this has already been discussed by Dr. Rajiv in terms of brain mets. If they are asymptomatic, we'll start with radiotherapy. And frequency, he did mention that durvalumab can be given 4 weekly. There is data about atezo also, which can be given 4 weekly with 1680 milligram of dose. And biomarkers, as of now, there are no proven biomarkers which can be targeted. So summarizing, I think both drugs are available for use in extensive stage small cell in combination with carbo etoposide, and if you are using cisplatin etoposide, only durvalumab can be used. And other immunotherapy drugs are not approved in this setting as of now. Safety concerns are not different from what we already know. And immune checkpoint inhibition plus chemotherapy is a new standard of care. Obviously, the biggest challenge is the finances. With that, I'll end. If there are any other comments or questions from any other panelists.